Welcome. It is time for Ask Dr. Geier Live. Wherever you're watching, hope you're making today your masterpiece. My name is Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, anti-aging and regenerative medicine expert. I help athletes and active people like you feel, look, and perform your best regardless of age or injuries. Yes, it is Friday, 12 p.m. Eastern Time. Once a month, usually the last Friday of the month, I do Ask Dr. Geier Live, the one place, the one time I answer your, usually it's orthopedic injury questions. Occasionally they're more health and wellness oriented, but that's what we're here for. If you have a question, if you're watching, please leave that question in the chat on YouTube, not in the comments below this video. Those don't come through to Restream, so I can't see them. I can only see the ones in the chat. If you're on X, formerly Twitter, you can try to leave your questions. They should come through, but it's very unreliable. So if you're trying to ask a question on X, watching it there, and it's not coming through, maybe come to the YouTube site on my YouTube channel, and then you can participate that way. I gave up on LinkedIn and I gave up on Facebook because Restream, they kept disconnecting their service, and it was just too much trouble. Most people are on YouTube. Also, please know, as I've said in the 50 or 60 of these or plus that I have done, I am not giving you medical advice. All of my answers are meant for general information and educational purposes only. I haven't seen you, I haven't examined you, I haven't looked at x-rays or MRIs. I'm not your doctor, you're not my patient. This is meant so you can have more information so that then you can go back to your orthopedic surgeon and say, hey, what about this? Or if you've already been to an orthopedic surgeon and you didn't understand what he or she was saying, maybe this can be sort of a translation for you, but I am not telling you what to do. So we'll start, and I typically stay as long as there's questions. So it can be as short as 5 minutes. So if you're holding off on putting questions and there aren't many, then it'll be short. But I've done these that have gone 45 minutes before, so you just never know. All right, Paul asks, what should rehab after microfracture of the talus look like? When to ditch crutches? Again, I can't give you advice, but here's what I'm thinking of. And just so you know, for people that are not familiar with the talus, let's talk about that. The talus is the bone under the ankle. I don't know how well you see that. So you got the distal tibia, you got the talus right there. Sort of the weight-bearing part of the ankle. And the microfracture is a procedure, it's done way more often in the knee than in the ankle, even though it has really fallen out of favor across the board. But it's a procedure to try to fill a defect of cartilage where there's exposed bone by poking holes with what looks like a fancy ice pick. When I say it's fallen out of favor, and again, it's because it was mostly done in the knee, maybe in the ankle it might work a little bit better, but it fills with what's called fibrocartilage and not the hyaline cartilage that turns into healthy articular cartilage in the knee and the ankle. So it's much more brittle and it breaks down with activity. There has been thought in the knee world, at least, that it actually may speed up the development of arthritis, albeit it seemed like a good idea at the time. And so a lot of sports medicine surgeons, and I was definitely in this camp when I was operating, would do surgeries to try to stimulate the formation of real articular cartilage or replace it, meaning move a cylinder of bone and cartilage from another part of the knee, or get it from a donor, transfer an entire cylinder from a donor, such as what's called an osteochondral autograft. Having said that, if somebody was going to go through a microfracture, again, where the surgeon pokes holes in the bone, lets it bleed, and over time turns into fibrocartilage, you have to protect that area until it turns into that fibrocartilage, and that's by basically protecting it and limiting unnecessary forces, meaning weight bearing. So this is not advice, that's a better question for your surgeon, but typically that's somewhere between 6 and 12 weeks before people start putting weight on it. And then you gradually work to get weight bearing, range of motion, strength, all of that kind of thing. All right. Could penicillin be used as a topical gel for arthritis? I have not heard of it as a topical gel. There is an oral form of penicillin that's used for interstitial cystitis in the urology world. It has not been shown to work for arthritis that way and has a lot of side effects. I have never heard of it used as a topical gel. It's not to say it couldn't be. Maybe somebody is studying that, but I am not aware of that. It's typically, again, a subcutaneous injection in the abdomen or the hip, glutes, proximal thigh, things like that. Harsha, grade 2 chondromalacia of the lateral tibial plateau. Is it a bigger problem? Grade 2, and again, chondromalacia is essentially early articular cartilage damage, and it's scaled 0 to 4, grades 1 through 4, 4 being the worst, 3 obviously less, and then gradually less. 2 typically means that it's a small area and there's no exposed bone, so it's typically not that big of a deal, but any decrease in articular cartilage thickness or damage to it potentially is bad. So is it a bigger problem, I guess, compared to what? But having said that, grade 2 would not be terribly worrisome, and there would be millions of people in this country, if you were to get MR arthrograms on the entire adult population, millions and millions of people that have that and don't even know it. They're not even symptomatic, so potentially not a big deal. Bella Vicky, fracture of the PCL. Not sure what that means. Confused when I try to Google this. Doc has me do PC. So all I can see, so the PCL, the posterior cruciate ligament, it's a ligament. So fracture means broken bones. This is the PCL in the back of the knee. All I can think that means is the PCL pulled a piece of bone either off the femur or more likely off the tibia. And so the ligament is actually intact. The bone that attaches it to the rest of the femur or the rest of the tibia is pulled off. And sometimes that can be fixed by putting a screw to hold it in place, or if it's non-displaced, just allowing that to heal potentially would actually be a better outcome than tearing the ligament, but it's a little hard to know exactly what that is. Voltaren cream, bad hip and knee pain. And that's what she's saying, fracture the bone under it. That's typically what that would be. And I've actually done that surgery. It's been a long time. It's much rarer than tearing the ligament. But if it's in place, in theory, you could be non-weight bearing and get it to heal that way. It would make me a little nervous because you'd want to limit range of motion, which is never good in the knee if you can avoid that. But the surgery is actually really straightforward, and you could advance the rehab much faster than the typical PCL reconstruction, which is 6 to 9 months minimum, more like a year. Voltaren gel, I'm sort of lukewarm on. I know a lot of orthopedic surgeons use it. The data is equivalent pain relief compared to oral anti-inflammatories like ibuprofen or naproxen, without some of the side effects, the stomach issues, the potential bleeding issues that anti-inflammatories, the kidney issues that those typically present. I have not prescribed it that much. I'm not a huge anti-inflammatory fan, and I have tried it myself back in the day and did not see that much benefit, but there's very little downside, and now it's sold over the counter. You could try it and see how it goes. My son's a college baseball player, dislocated his shoulder last summer, started full baseball activities January, played all season, no soreness in the throwing arm till this summer. I'm not sure what the question is, but usually there's two possibilities here. Again, not medical advice because I can't see him. One, it just needs physical therapy to improve range of motion and strength and provide dynamic stability. But in a young athlete, I talked about this in a video that I recorded a few days ago that we'll post on my YouTube channel within the next few weeks. A first-time shoulder dislocation where the ball is outside the socket and somebody has to put it back in, or basically a full dislocation. Very, very high rate of capsular and labral damage, and much of orthopedic sports medicine has progressed to doing surgery for a first-time shoulder dislocation in somebody under the 21 years of age, just because there's an extremely high recurrence rate. Don't know if that's going on here, but that's what I would at least thinking about. And then strengthening exercises, that'd really be a better question for a physical therapist than me. It would be strengthening the periscapular muscles on the inside of the shoulder blade, the rotator cuff muscles, things like that. Flash White, can taking oral peptides help with overall arthritis as we age? Well, there aren't many peptides that are absorbed orally. Really, of the ones that have any orthopedic effects, BPC would be the one. And in theory, if you read the absorption and bioavailability studies, BPC orally is absorbed just as much systemically as an injection. I will tell you anecdotally, oral BPC does not seem to do much at all for orthopedic issues. It's not to say you couldn't try it and see. It's certainly easier than a daily injection, but that's just what I would worry about, is that oral BPC may be a super expensive product. Now, buying the stuff online, which is again largely fake and is cheaper for a reason, but true BPC made by a true compounding pharmacy, it does get expensive, and I don't know how much benefit there would be to oral BPC. The only study on BPC that I'm aware of for arthritis in humans was where it was injected into the knee. It was a terribly designed study, but it did show good pain relief. Now, patients themselves cannot inject BPC into their knee. That would be a horrendous idea, because you would very, very likely introduce infection into your knee. But physicians that do peptides could do that. I don't know how much benefit there would be to, maybe as an alternative to cortisone, maybe not. But sub-Q injections of BPC near the knee potentially could have benefit as something you do daily in the distal thigh muscle, something like that. Mary says, is starting with the grinding. What can I do? Fill me in. Maybe she did it here. How can I stop arthritis? What can I take? And grinding related to arthritis, there's not a lot of easy treatments for that, because at the end of the day, that articular cartilage in the arthritis is not smooth anymore, whatever the joint is, and it causes a grinding sensation. No medication, peptide, something like that, is going to make it. In cortisone is going to make it. Physical therapy is going to really change that. In theory, a regenerative treatment could fill in an area of exposed bone if there was enough cartilage damage that's the issue. But even then, that would be a long-term process. Typically, and then back to her question, how can I stop the arthritis? There aren't that many conventional treatments that have been shown to reverse the course of the arthritis. Certainly cortisone shots and steroids do not do that. If anything, they speed it up. Anti-inflammatories do not stop the underlying inflammatory process. They're purely relieving pain, maybe some inflammation related to that. They don't stop the process. Surgery, such as arthroscopic cleanup surgeries, arthroscopic debridements, do not stop the progression of that. In fact, they can make it worse and speed up the need, especially this has been studied in the knee. So that's not an option. As far as experimental or off-label treatments, penisin polysulfate, as we talked earlier, does seem to be able to at least stop further damage. We don't know if it reverses it. There are some animal studies and one human study looking at metformin as potentially being able to do it, rapamycin potentially being able to do it. Those would be the ones potentially I'd look at, but again, all of that is either off-label or experimental. Well, I guess all three would be off-label uses. None of those are experimental, but that's and as such, it would not be covered by insurance. Penisin hopefully will be FDA approved and in traditional pharmacies over the next year and a half, something like that. And then that will become something that hopefully can help millions of people. Early mucoid degeneration, Harsh asks, is just essentially just that. Early, as we get older, the ligament structure, the collagen fiber network starts to get internal degeneration of the ACL. Honestly, it's a radiology finding, typically doesn't mean much of anything. It is not really thought to be much as far as a source of pain. It's typically something that is found on an MRI while you're looking for something like a meniscus tear or other kinds of problems. If somebody had a clean MRI, no meniscus tear, no articular cartilage damage, no other ligament damage, and they had early mucoid degeneration, I wouldn't do anything personally. I wouldn't, if it was a patient of mine, I wouldn't physical therapy or anything else. Now, if you got an MRI for a reason, so there's pain involved, maybe potentially you would do physical therapy or something like that. Also, you could argue maybe that's where something like peptides or regenerative treatments may play a role to try to strengthen that ACL. The argument against that would be that's a long way to go and a very expensive treatment for something that may not matter. We don't think that leads to a higher rate of ACL tears down the road. Kaylee, what would you recommend? I covered myself up. What would you recommend? Next step of treatment, shoulder replacement. Sorry, my thing is covered here. I'm going to scoot this up. What would you recommend? Next step of treatment, shoulder replacement. I may have missed the first. I don't know if there was a question before that. I'm assuming shoulder arthritis. At 27, if that's what the diagnosis is, glenohumeral arthritis, which would be in the ball and socket part of the shoulder, which you can't really see because it's covered up by muscles here, but in this part of the shoulder, typically what you're thinking about there is some kind of efforts to regrow bone and cartilage. At 27, personally, I'd want to know more about that. What led to glenohumeral osteoarthritis at 27, and if there's I can't say I've ever seen that in a non-weight bearing joint, so I would certainly want to know more about that. But having said that, if the cartilage and bone are exposed, maybe regenerative treatments might be beneficial. I wish I could give you a more specific answer. Something to me is not adding up there, but it may be legit. It just I'm not sure I necessarily know what's going on. But you certainly shoulder replacements would not. The worry is at 27, is that likely to last till somebody's 70 or 80 or 90 and not going to need a revision? Very, very unlikely. Plus, the problem with shoulder replacements, they're very good at relieving pain, not very reliable at all at restoring function of the shoulder, and that's what makes that tricky. Fez, low grade, I assume that's calf tear, or maybe I'm not sure what that is. Maybe that's ACL. Signal 2, medial meniscus, no evidence of tear. I, again, can't tell you what to do. I can't do medical advice. And I'm not sure, to be fair, I understand ACL. Low grade ACL tear. I guess it would depend. This is a good question for your surgeon. Is that ACL and is the knee unstable as it relates to it? Low grade tear is a radiology term. It doesn't tell you clinical stability of the knee. There, as I've said in other videos, partial ACL tears are exceedingly uncommon. Yes, the radiology report, MRI report says that all the time, but most of the time, enough of the remaining ligament is stretched out that essentially the knee is unstable. I don't know if that's what this means or not. Kaylee went for shoulder surgery on Saturday, grade 4 chondral loss. Crazy at 27. Yeah, I'm not really. The only area where I can imagine seeing it is somebody that's had a lot of shoulder dislocations, and just every time it pops out of place, it knocks more and more bone off. Fortunately, though, the shoulder is not a weight-bearing joint, so typically cartilage damage is not as detrimental as it would be in the hip or the knee. But yeah, I think that, again, this is not advice, but that's maybe a good place to start with exosomes, stem cells, some of the regenerative treatments to try to regrow the cartilage, maybe something like penicillin, polysulfate to stop any future damage. But again, not necessarily medical advice. And again, when I talk about regenerative stuff, I'm not pushing that on you or anybody else because it's experimental, it's off-label. I'm just putting it out there as kind of things that are potentially available for people that want to look into those and sort of an idea of what's coming. Dennis Bolaños, torticollis, that is a pediatric condition where you get very tight muscles. That's really sort of outside what I do in the sports medicine world, really for the pediatric orthopedic surgeons and the neurologists, so I don't have a lot of thoughts on that, unfortunately. I wish I did, but I don't. Prognosis on shoulder replacement, that's what I was getting at earlier in relation to somebody else's. Very good results for pain loss. It typically takes care of that well. What it does not do very well is restore function. Getting your arm overhead and doing overhead activities, repetitive overhead sports like tennis and things like that. So a lot of times manual laborers are fairly disappointed with the outcomes, but if pain is just excruciating, can't do any of your normal daily activities, no other treatments have gotten really any significant improvement, that's when it typically becomes a reasonable option. Georgia calling in checking in from Greece, good to see you. Be a great place to be. And then Fez says the knee is stable. Yeah, for a stable knee with signal change in the meniscus, or yes, maybe a partial, very small ACL tear, but the knee is stable by exam, I think, and again, not medical advice, but what I'd say, maybe that's a place where physical therapy might be a little more useful. And as I told Fez, as I told the person earlier, I'm not a physical therapist. I'm not the person to ask for that. if I don't formally refer them to physical therapy, is find a good physical therapist. Go for one visit. They do the exam, they do a full evaluation, they outline a program for you, show you how to do those exercises, and then you do them on your own. I think can be a reasonable option. All right, we are going to stop there. I really appreciate it. Lots of great questions. Thank you so much for being here this Friday. I hope you have a fantastic weekend. Next month, we're doing it a little early. It will be August 16th, so not the last Friday of the month. So mark your calendars or go onto my channel. There's a link to it already. You can mark to be notified when that starts. I really, really appreciate it. These are great questions. It means a lot to me that you trust me enough to sort of give you insight on that, and hopefully it helps you talk to your orthopedic surgeon, talk to your doctor, and consider different options than you might have thought about before. Have a wonderful weekend, and I will see you all very soon.